Hi, welcome to Myth Busting Menopause. Myself and Claire have been menopausing for a while now. Claire, how old were you when you first started menopause?
Well, I think I went straight into menopause at 18, so after my treatment. So it's been, giving away my age, but about 23 years. It's been a long old menopause for me.
And I went into menopause at 36. So my math isn't great, but I think between us, we have about 33 years menopausing experience. But we're not just busting these myths by ourselves. We have 7 myths, and that's why we are joined by Dr. Juliet Balfour and Hannah Gibson. And Hannah Gibson is a women's health physio. Thank you so much for joining us for this today.
The pleasure.
Yeah, it's so great to see you. So we just thought that, we want to talk about early menopause as a result of cancer treatment specifically. We were chatting about this and realised that our model for what menopause looks like often comes from our mums, and that's really not the same as what we go through as younger adults, particularly when it's as a result of cancer treatment. And so often it can be quite difficult to know where to find good information about the impact on younger people, and you end up falling back on those old myths or misconceptions, or maybe just watching a TV show or Dr. Google. So we thought it would be great to have a myth busting session where we could ask people who know the actual answers, So just before we start looking at those myths, we thought it'd be just interesting to hear really quickly from Dr. Juliet about your interest in the area and a bit about your experience.
Sure. So I've been an NHS GP for about 30 years now, and specialising in women's health. And I'm now also a menopause specialist. So it's a particular interest of mine for women going through menopause at all ages. And yes, as you've shown, it can be a great variety of ages. And I'm just really keen for people younger people particularly, to know what to expect, know what they might go through, and then obviously know how to manage it.
Oh, thank you. And Hannah, do you want to just introduce, we have to admit, before we spoke to you, we didn't actually know what a women's health physio was. And that's why it's so great to have these sessions, because we learn new things as well. So do you want to just quickly explain to us what your work entails?
Yeah, absolutely. And it's quite common actually that people aren't quite familiar with what we do, because people are used to hearing about physios when maybe they've injured a knee or they've got tennis elbow or something. But women's health physiotherapy is a particular specialism where we look at the pelvis. So it's all things bladder and bowel, and also things like pelvic pain come into it. So more of the musculoskeletal things that people are more familiar with physios addressing. So we cover things like urinary symptoms and also bowel symptoms. So urinary symptoms, there's a massive spread. So you have some people who maybe have a slight loss of control when they laugh or cough or sneeze, all the way through to people who have more obvious accidents. So yeah, a real spectrum, everything bladder and bowel. If it's within the pelvis, then we address it.
Brilliant. That's really good to know.
Absolutely. So Tatum, are you going to kick us off with our first myth?
Yeah, so our first myth, the big one, is that menopause is no big deal. I mean, it's natural. Everyone, women go through it and have been going through it for millennia. And, I think a lot of us also have this reaffirmed, we've just been through cancer, or we're going through cancer. How big of a deal can menopause be? So yeah, Dr. Juliet, can you share your thoughts on that? Is it a big deal?
So menopause, yes, it is natural in that we'll all go through it at some point, but goodness me, it can be a big deal. It's very variable, but there are so many symptoms that are due to lack of estrogen. Some people say 34, some people say more. It really depends how you classify each symptom, and some of them can really affect your quality of life. And if you do have a menopause earlier due to cancer treatment, I'm afraid it is often worse because it's so dramatic. You're not having a natural decline in your hormones that your body gets used to some degree. Depending on your treatment, you may suddenly sort of go from lots of estrogen to no estrogen and no testosterone. And it can really affect people seriously, and it can have long-term health implications. So it is really important that we do help people get through their menopause.
Yeah, and it's interesting you talk about symptoms, because that's actually our second myth, which is that we quite often hear is that the only symptom of menopause that's really notable are the hot flashes, because I think that's the one that is kind of everyone knows about. It's the one people joke about when they're out and about and going, "Oh, having a hot flash that time of their life." You know, that kind of chat that we hear, which can be difficult when you suddenly start experiencing all sorts of things. You don't know whether it's to do with menopause or not. So yeah, if you don't mind explaining a bit about the extent of those symptoms.
Sure.
Describe,
So the hot flashes and the night sweats, as you say, are the classic one, and that can often make people think, oh, hang on, maybe it's hormonal. But you know, about 20% of people don't get those at all. I think the biggest thing that people need to be aware of is the psychological symptoms, actually, of lack of estrogen, because a lot of people don't realise. So some people get very anxious, get panic attacks, don't like driving anymore, not wanting to drive on the motorway is a classic one. People can get low mood. They can be more irritable. If they tend to get PMT, they can get much worse PMT. And they don't feel their brain is working properly. So you can get brain fog, and sort of you can't remember stuff, and you can't remember that your names of things that you normally know. And you can't concentrate so well, and you're less motivated to do stuff, and can really affect women working. And a lot of women actually think, gosh, I can't cope with my job anymore, which is a real shame. So you've got all these awful psychological symptoms, and then you've got physical symptoms. So obviously the potentially stopping periods, the potential hot flashes, night sweats. Then you've got lots of other things. So aching muscles and aching joints is a big one. And some treatments do make that worse. Everything dry, so dry, itchy skin. There's a horrible thing called formication, which is when women feel that there's something crawling under their skin, which is a horrible condition. But you can get drier, thinner hair, and dry eyes, and a dry mouth, and a sort of burning tongue, or a funny taste in the mouth. And we'll talk a bit about things get down below, so you can get a dry vagina, and your vulva, which is the bit on the outside, that can get dry and itchy, and you can get more urinary problems. And your libido can go down, and sex can become painful. And buzzing in the ears is another one. Restless legs at night is another one. I've probably forgotten some, so people in the audience are going to shout out from their homes, because I'm sure I forgot. But yeah, there is lots. So a myriad of different symptoms.
Yeah, I mean, it just sounds super fun, doesn't it, really?
Yeah. Some people get none of them. A few people don't get any. Some people get all of them, and lots of people get just a mixture of some of the physical, some of the psychological.
Yeah, and I think a thing worth pointing out at this point as well is that often, if you've had menopause as a result of cancer treatment, you've obviously also got going on a lot of new medications in your system. You are dealing with a whole load of other physiological changes. As for me, because it was sort of straight after a transplant, a stem cell transplant, which, you know, can take you a year to get over. I just didn't have a clue which symptoms were related to what. So I would never have thought to say, oh, these could be menopausal, and could look for sort of solutions in that realm, rather than just putting it all down to cancer, which I think makes things difficult.
Yeah, and a big one I didn't mention was poor sleep. So that is a massive one, and the fatigue again, like you get with cancer treatment, and some people get terrible sleep because they wake up at night with night sweats, and they're soaking, they have to change the bedclothes. But other women just get this change in their sleep. In the middle of the night, they just wake up like a light is switched on, and they just can't sleep for 2 hours. Their brain is just really active, and they can't sleep. And that's another big issue that then obviously impacts the rest of your day when you do wake up in the morning. And that can be a pretty great one to cope with.
Absolutely.
Yeah, they can really kind of cycle round and then cause more, can't they? So one thing leads to another. Like bad sleep can lead to so many other issues as a result of it. Yeah. And so one of the things that I know was thrown at me a lot was all you need is some black cohosh, and all you need is this supplement. Oh, it will balance your hormones. But I had my ovaries removed. I was like, I don't think there's any balancing that's happening here. Like I had them removed with no HRT. Like there's no balance. So what's your kind of, have you heard about these magic supplements that will make it all okay?
There is, I mean, unfortunately, there is a massive industry now in these sort of things that have pushed at people, you know, who are going through the menopause at any age. And most of them don't work, and lots of them cost a lot of money. And obviously women are desperate, and they might not have had medical advice about what to do. So obviously they turn to the internet and they turn to these things. So we don't recommend black courage to anybody because it can cause liver problems. If you're on it, don't worry. You probably haven't caused liver problems, but stop it. But all these herbal treatments, firstly, a lot of them aren't licensed, and we don't know the quality. We don't know what's in them. If you do go for herbal supplements, they need to have THR on them, which means they're regulated. But research has showed, unfortunately, that herbal treatments do not help with any of the menopausal symptoms. So really, we don't recommend any of them. And some of them actually do interfere with other medication. Lots of things, for instance, interfere with tamoxifen. So we wouldn't recommend you taking anything really without checking with your doctor first.
Yeah, and I guess it's interesting talking about all the alternatives to HRT effectively is what those come into, and it can feel like, and this is another of our myths, that HRT is really the only way you've got to treat symptoms. And obviously, if you've got a hormone responsive cancer and that's kind of ruled out for you as an option, it can feel like, well, I don't have any options then. Like, what else can I do? And it feels like an issue that we should be quite clear about, because we should know either way, but actually even between Tatum and myself, we've had differing advice from different doctors, and oncologists don't always know everything about the hormonal treatments, and you might expect them to, but they don't seem to. So I was just wondering what your response to the idea that HRT is the only way to treat symptoms.
Sure. So firstly, you're absolutely right. There is a lot of discussion and debate and controversy about HRT in all sorts of realms and other hormonal treatment. So I think the first important thing to say is, if you're young and you've had a non-hormone related cancer and your ovaries have been taken out, or you've had pelvic radiotherapy or had chemo that's damaged your ovaries, it is really important to talk to your doctors about HRT, because if it's non-hormone responsive cancer, you're not going to cause any recurrence or do any harm, and you need the HRT for your long-term health. So that's very important. Yes, if you've got breast cancer or some sort of very advanced cancer of the line of the womb, and a few of the ovarian cancers can be hormone responsive, and yes, with them certainly you wouldn't consider HRT first line, but there are lots of other things out there that can really help with your symptoms. And sadly, unfortunately, a lot of oncologists at the moment don't know, or breast care nurses don't know, or GPs don't know about these options, but they are out there, and we're trying to get education out about it. And almost in a way, at the moment we're saying, well, patients get educated, here's some good websites, talk to people like you guys, and what is potentially going to help you, and then you can actually ask your GP, and then your GP can do some research if they're not sure, and just check, and then hopefully offer you some help. So really good things. But CBT has got massive evidence base for really helping, firstly with the sleep problems that people get with the menopause, and also it can be shown to really help with managing the hot flushes and night sweats. So that CBT is a massively brilliant evidence-based.
Just in case, I'm sure people do know, but just in case, explain what CBT is for us.
So it stands for cognitive behavioural therapy, and you can have it. Nowadays, you can do it online, just on your own, or we offer group consultations doing CBT. And actually, the studies show that group consultations with CBT works really well when you're in a group, because you all support each other and encourage each other. And actually, for insomnia, there are various NHS options that you can. There's various insomnia programs that you can do online that you can access by the NHS, and it basically looking at your response to symptoms. So if you're waking up in the night with an awful night sweat, and then you wake up and then you lie there and you think, oh my God, I'm not going to cope with work tomorrow. I'm going to be really, really tired. And I've got that meeting and I'm not going to manage, and I'm going to have another sweat then during that meeting. And that all those thoughts running around your head in the middle of the night, it's not going to help you sleep, and it's just going to make everything worse. So CBT sort of looks at your thought processes and how you react to your thought processes, and helps you reframe things in in a way that sort of helps calm you down and helps you cope with everything. That's a really basic thing, but there's lots of stuff out there. But it works really well.
Absolutely. I mean, I've heard good things, and I definitely relate to that nighttime unhelpful thought spiraling. That's definitely a thing, isn't it? And I know, Tatum, I mean, you've had an experience of finally getting a medication that's not hormone based after many years of looking, right?
So I had asked my GP 8 years ago. I had heard of this place called the Menopause Clinic, and they had things like acupuncture, and I found, like, you know, I just imagined walking in the doors and coming out like, oh, a place that I could be understood. And the response I got was, yeah, that's not for you. There's nothing that can be done. And I was like, oh, okay, I'm hopeless. So I, you know, plowed on, because that's what you do when you have like a lot of symptoms, but they were affecting every single part of my life in really detrimental ways. And 8 years later, so fairly recently, I finally got referred to the menopause clinic, and it actually was a moment. They put me on a medication that reduced the night sweats, and I've been able to sleep for the first time in 10 years. And I'm dreaming like a crazy person. They're amazing. I think I've got 10 years worth of saved dreams. And it's transformed my life being able to sleep, because I'd never gotten sleep together before. It had always been broken up. And and I didn't know that anything like that was even available, you know, that was non-HRT.
I think the message is, sorry, I was just going to say, is to be persistent, isn't it? If you don't get an answer straight away, don't take the first answer if it's not what you want to hear.
Yeah, so we do have the hot flushes and night sweats, which can affect sleep. You know, we call them vasomotor symptoms, and we do have other medication, as you found, to help with that. So there's particular types of antidepressant, and there's one particularly called venlafaxine we often use first line, and that can really help with hot flushes and night sweats, and also help a bit with sort of anxiety. But the main reason we're giving it is to help with the sleep and the vasomotor symptoms. And then we've got other medication that's related to pain medication, but has also been proven to help. And it's another one that, in fact, we usually use for bladder problems that also helps with night sweats. So often we will try one. You know, I tend to try things at really low dose and slowly build up, because as usual, everything has side effects potentially. But you start low, and if one doesn't help, you try another one. And you know, there's a sort of we can try all these different drugs to see if it can help the problems. And then there's lots of practical advice and issue, and then all the lifestyle advice is obviously incredibly important to sort of help people manage their symptoms. And at some point we'll need to talk about local estrogen, but I don't know when we'll talk about that in the myths, but we'll
I mean, the next one is actually the next myth is menopause ruins your sex life. You know, that either you're not going to want it, like your libido is going to go, or you're not going to be able to physically have it. So I imagine the local estrogen would come in quite handy in that.
Okay, so this is a massive issue, and we're all embarrassed to talk about sex, aren't we? You know, doctors don't want to talk about it, patients don't want to talk about it. So there are so many people suffering because of this issue. So I'm so pleased that we can talk about it. I could talk about this all day, because it's such an important issue. There's lots of things if you've had cancer. So obviously, firstly, your body image, your body might have changed with surgery. You might have put on weight, you know, due to all your treatments, and you just might not be feeling yourself. So that's an issue. Libido can be affected by our hormones, and if our hormone levels are changed, and if we're feeling tired and unattractive or whatever, that can really affect our libido. And then, yes, sex can become painful. So yes, unfortunately, potentially menopause can ruin your sex life, but there's lots we can do to prevent that and help that. And again, if you've got night sweats or you're not sleeping, you're going to be tired. And if you're tired, you're not going to feel like having sex. So a few messages, really. I know we can't go through everything on this topic, but, you know, communication is really important. If you've got a partner, talk to them, explain that you're worried, explain let's go slow, you know, explain that you just don't want to go and have some sex straight away. And you can be affectionate without full-on penetration and sex. That's the first thing to say. The second thing is that you have to be really careful what you use vaginally, because everything, when you lose estrogen, your vaginal tissues can get much thinner and more sort of friable and more sensitive, and you lose the natural lubrication. So it's very important to use lubrication during sex, but it's very important to use the right lubrication, because lots of things you can just go to the chemist and buy. They've got colours, they've got perfumes, they've got parabens, they've got alcohol, they've got irritants, and you can actually find it can make your symptoms worse down below, because everything gets worse. So am I allowed to mention brands on this? We all menopause doctors, we recommend the Yes products, yes.org. They're good, they're organic, they've got nothing in them that's going to damage the area, and they have all sorts of different options. They have vaginal moisturizers as well, so they're a really safe bet. You can ask for them from your GP, or you can just buy them online very easily, but definitely you can use the lubricants when you're having sex. Is really important. And then some people, if they've had surgery or radiotherapy, their vagina does get smaller and shorter, and it can sort of, especially if you haven't been having sex for a while, it can all sort of shrink a bit. So another good option is vaginal dilators, which you can buy, and you can just start yourself on your own in the bath or wherever you feel most relaxed, and just start very slowly using these tiny dilators, and you just go bigger and bigger and bigger until you feel that things have dilated enough. So that's another good practical option. And just the other thing is that most people can safely have vaginal estrogen, so that's local estrogen. Not everybody, it depends on what treatment you're on, particularly with the breast cancer patients, but a lot of breast cancer patients, with discussion with your oncologist, it is safe to have local estrogen. It's tiny doses, and you can have pessaries or gels or tablets or all sorts of, or rings, all sorts of ways, but you can deliver local estrogen to the vagina, and that plumps everything up again, makes sex more comfortable, reduces urinary tract infections and urgency and getting up at night to wee and all those other things that can come on with menopausal symptoms. So that's my most important message for today, is talk to your doctor about vaginal estrogen. They might have to, ask your oncologist, because as I say, not everybody is confident with that, and it depends on your treatment. But that is a really important thing. It will make a massive difference to your sex life, your sleep, your urinary symptoms, and your health moving forward.
Just to add from a pelvic floor point of view as well, and we often talk about the pelvic floor, and we're saying to people, do your exercises and get your pelvic floor very strong, but within the context of sex, particularly if there's been any kind of trauma to the area, if that's been a surgical site or there's been any radiotherapy, we can see that the pelvic floor becomes quite high tone, and particularly if you're expecting something to maybe be uncomfortable, it might be that muscle is a little bit more active than you'd want it to be, and that can ultimately make things more difficult, because there's a greater degree of tension in the area. And there's a lady called Maeve Whelan who's developed this physiotherapy technique, and it's really easy to do. All you do is you sniff in through your nose at the same time as letting your lower abdomen kind of flop out. At the same time, you should feel the pelvic floor drop down. So it's just a really quick sniff in, your lower abdomen drops out, so you're not tensing anything, and you should feel the pelvic floor drop. And it's a good test to do. If you can feel that drop quite easily, you're probably in quite a nice position, but for some people they don't really feel much of a drop, and it's a nice thing to kind of test. If you want to have a look, it's just Maeve Whelan, you can Google it, and she goes through all of the steps. It's quite a nice thing just to try.
Well, that's brilliant. You can just see me trying not to do that on camera. Yeah. Absolutely.
I do think that this is a really massive thing. As someone that hasn't been able to have any kind of penetration, and even in recent years not even be able to go for a pap smear because they couldn't, the doctor basically said it would be unethical to keep going because it was too painful. I felt a lot of shame around that. And I think that shame stops you from talking to the doctors or asking for help. And then I was meeting other women that also were disclosing in this very carrying this heavy shame. And when I saw them just, saying, oh, well, actually I can't have penetrative sex with my partner anymore, and the whole body is going in, I wanted to go, oh no, it's okay. And then I realized, oh, I'm walking around like that, but I wouldn't treat somebody else like that, you know? And so I went to a specialized nurse, and for me, anything inside felt like broken glass. And when she said, oh yeah, you know, sometimes that's what it feels like, it was the first time that I felt understood. And so I just thought I'd share that, like, even if you feel like you're broken beyond, like, just knowing that there are things and there are people that can help is actually really encouraging. And knowing that there's different things for the pelvic floor, because I think, again, like, a lot of people feel like, oh, you know, if they're having urinary problems or whatever, like, there's nothing that can be done. So knowing that that's available is really, really useful. And thank you for that test.
Definitely. And I mean, that's a great one. I just also add from my experience, obviously I went into treatment at 17. So my sex life pre that was pretty much non-existent. So obviously all of my adult sex life has been in menopause. So it's very difficult to know then. You start to think, oh, am I just bad at sex? Like, what? Because I didn't have anything to compare it to. And you go, are these problems I'm having to do with me or to do with, and you might not associate them, particularly if you've gone through it really young and you don't have a great experience of what sex feels like normally for you. You've got very little to compare it to. So I think it's always worth kind of, if you are having any issues and you're not quite sure, just ask. And like Tatum says, there's a lot of people out there. Don't feel embarrassed about it. It's a really important one to talk about, isn't it? And it kind of brings us, our next myth actually was, you mentioned it, Juliet, about body image and how that can change. You know, the myth is maybe it's not a myth, but menopause changes the shape of our bodies. You know, our body image can be affected, and that will have a particular impact probably on how we feel about intimacy. That maybe, you know, you hold weight in different places after menopause and you feel different, and it's trying to regain your sense of identity around all that. What's the truth? What's the science behind the fact that your body changes shape?
Yeah, so sadly this isn't a myth. I'm really sorry. So basically, as we lose our estrogen, well, various things happen when we lose our estrogen. So our muscle mass goes down, and our basal metabolic rate goes down. So the amount of calories that our body is using up when we're just sitting doing nothing goes down. And our body is desperate to provide estrogen, and so it changes where we put our weight. So we all start to put on more weight round the middle, round the tummy, and that's because sort of abdominal fat and the fat round our organs does produce a weak form of estrogen. And so our body's very clever, so it's basically changing where we put fat to produce some estrogen. So even women who haven't had cancer, who are going through the menopause, they're eating just what they used to, they're exercising just as much or more, but they're still putting on this weight around the middle. So unfortunately, yes, it is something that will happen to all of us as we lose our estrogen. But it's not, we can counteract it, and it doesn't affect everybody to the same extent. But if you do notice you're putting on weight around the middle, it's not your fault. It's evolution. It's our body's doing it to us, I think. So that's then when you're feeling up to it, is when all the lifestyle things come into play with what we're eating and our exercise and reducing stress and sleeping enough and our emotional health. All those things come into play to help with that weight gain.
And I think there's something in there, isn't there, about how we talk to ourselves when we're going through these things. Is quite often it would be the messages I would tell myself if I put on weight, wherever those come from, and that's a whole other session, isn't it? But oh gosh, I need to do this. Something's gone wrong. I'm getting really, I've got definitely weight around my middle that I'm not that happy about. But I think it's the way we kind of go, oh, actually, that's my body doing its thing. It's doing its best to balance out what's happening to me and give it a bit of a break. Really, let's be a bit kinder to ourselves in looking at why these things happen. And maybe that'll help have a whole change of perspective around it all.
I mean, definitely, and we have like such a strange relationship, particularly with abdominal weight. I mean, there's lots of women that won't touch their stomachs, and like even kind of claiming ownership of that area, like if it doesn't look a certain way, which I think is, kind of goes to like obviously a larger thing in our society, but there's something particularly about abdominal weight that many people struggle with.
Yeah. But yes, but look at any woman in their 50s and they will be carrying more weight around in their middle. And, we're becoming more like the male. We basically become more like the male distribution, which is, we think of chaps tend to put on weight around the middle and they get their beer guts eventually. And, that's not going to happen. We're not going to get beer guts. But yeah, it's one of those things that happen. And you're right. We've got to be kinder to ourselves, and Instagram and social media is everybody touched up and looking wonderful and having a special lights on their faces and filters, and it's in reality we're none of us are perfect, and we all have bits of our body we don't like, but keeping healthy is the most important thing, and managing your symptoms and getting as good as you can be.
And I almost forgot the last myth, which is,
that's a terrible joke, Tatum.
So menopause, making like the myth is, does it make you successful?
Yes, it does. Absolutely, it certainly does. So this is the brain fog I was mentioning at the beginning. Just people thinking their brain's like cotton wool. They just can't think straight. They forget names. They have to write everything down. I write everything down. And it can be just really, if you're used to, if you're working and used to sort of getting stuff done, and then suddenly you can't, you don't want to speak at a meeting because you think you'll forget your words. You forget to do things. You make mistakes at work. And that is your hormones. Again, it's not your fault. It's your hormones that are doing it. And there's a whole push now for more sort of understanding about the menopause in the workplace, and sort of make it easier for women at any age who are going through menopausal symptoms. So rather than being a butt of jokes, to be actually understanding and say, okay, I understand, and is there anything I can do to help? And here's a whiteboard for you to write things down to remind yourself. There's all sorts of ways that people could be helped to carry on with work, and again, but it's not your fault. That's the big thing. And you're not getting dementia. That's the other thing. Women of all ages think, oh my goodness me, I'm getting dementia. I'm getting early dementia. But it's just it's a natural part of the menopause, and it gets better. That is one that our brains seem to get used to, and it does get better. Lots of these symptoms do get better. I don't want to be painting too gloomy a picture. Our body does get used. You get this. If you get a dramatic menopause, it's awful for a while. But then your body does adapt, and a lot of these symptoms do get better. The only thing that doesn't is the dry vaginal and urinary symptoms that we talked about, which is why it's so important to manage those long term. But a lot of the other symptoms you do get through, and out the other side you do think clearer again, and things are easier again.
Yeah, I can attest to that one. Having been out the other side for a while now, like the night sweats and the sleeplessness, and I mean, brain fog is a tricky one, because I think obviously a lot of us also talk about chemo brain and fatigue, that come with it, and it's all sort of a bit muddled. But a lot of the other symptoms have definitely improved vastly for me. So yeah, I can hang in there, people.
Is there a way to distinguish between chemo brain and menopause brain? Because I know some people who were, in longer term treatment were thinking it was their chemo that they were struggling with. But actually, when they got some support for the menopause side, they realized that the chemo wasn't what was causing it. It was more the menopause symptoms. Is that kind of trial and error of like just knowing that it could be one and the other? Is there any way to distinguish?
Not that I know of, I'm afraid. But yeah, I think you're right. It is trial and error, and trying what you can to improve aspects, and seeing what you're left with. But so it's pretty mean having both of them at the same time.
Yes, totally. I know from. Oh.
No, you go. Sorry.
I was going to say, I know for myself, one of the things that happened to me was I ended up developing a stammer, and I was always a big old chatterbox and was used to being in front of people. And so forgetting my words was incredibly paralyzing. And so I had like basically some aphasia. And so people's names were like, oh no, it was just awful. And so I would always like write down people's names, and I would forget people's names, and I felt awful until one day I was at the end of a yoga class, and I just taught the class. and someone came up to me and she was like, "Oh, what's your name again?" And I said, "Sarah." Her name wasn't Sarah. There wasn't a Sarah around. There was no reason that out of my mouth came the name Sarah. And I couldn't even get away from because someone behind her knew what my name was. And it was really close. And so she pops up behind and goes, like, "Why are you calling yourself another name?" And I went, "I'm so sorry. My name is actually not Sarah. It's Tim, and I don't know why I said that." And since then, my anxiety about getting other people's names wrong just lifted. And you know that thing of like, oh, I'd forget my own name. I can go, I've honestly forgotten my own name. It is not any reflection on anyone else. It just, naming words. And then you think back to like, you know, your grandma going, Sarah, John, Sue, Harry, you know, like listing the names.
I think such a big part of it is finding a way for you to communicate to other people what's going on in a way that feels comfortable and gets rid of that anxiety, isn't it? It's just whether it's humor you fall back on or just being upfront, honest, blunt. It's kind of finding that way to talk about these things is so important. And I just go, I'm terrible with names. I'm so sorry. We may have met 6 times before and it's nothing to do with you. I'm a wrong and just tell me again. Like that's kind of, and I just tend to do that all the time. So
but it's that
finding these ways
nightmare
to talk about them.
When you're in a group or you go up to a group or you know one person or you know all of them and the other person you're with doesn't know any and you've got to introduce all the people in the group.
Absolutely awful. But I think it is. It's just about owning it.
Of the one side introduction, I go, everyone, this is Tom. Tom, introduce yourself. You're like,
well, I think we could keep talking about these myths, and it's been so lovely to talk to you. It's only through lack of time that we're stopping so that we've got time for other questions. But thank you so much. It's been so great to chat with you guys, for us as well. So we really want to open this up to the rest of the group. Questions for Tatum and I about our experiences, or for Juliet and Hannah about kind of more medical questions. We will be coming to you live. We may look different. We may be wearing different outfits, but we cannot wait to see you in a moment.